this clinical challenge article titled Persistent Facial Paralysis Diagnosed as Bell's Palsy, we highlight a clinical scenario that is somewhat frequently seen among facial nerve clinics. The details of this particular case highlight a larger clinical pattern that is unfortunately seen more commonly than we would like. That is, patients getting a diagnosis of Bell's palsy, but then not being followed up to assess for recovery, and potentially missing the correct underlying cause of their facial paralysis, which may be much more serious. As we know, Bell's palsy is the most common cause of facial paralysis, but it's also a diagnosis of exclusion. For acute onset facial paralysis, a thorough history and physical must be done to rule out other causes. Our Otolaryngology Academy guidelines currently recommend against routine imaging or lab testing when the evaluation supports Bell's palsy as the cause, but these tests should certainly be considered when there are signs or symptoms suggesting a different diagnosis. Most commonly, these can be teased out by asking about the timing of the paralysis onset. Bell's palsy happens quickly, usually over the course of 1 to 3 days maximum, and it affects the entire side of the face. Paralysis that takes longer to develop or starts in one region first before extending to the rest of the face is not consistent with Bell's palsy. Additionally, the involvement of other cranial nerve deficits, such as facial numbness, chewing or tongue weakness, and vision changes, should suggest another diagnosis. In these cases, MRI imaging of the brain and face should be done to really evaluate for a possible malignant cause. In the case of the woman presented in this paper, she had a remote history of what she thought was a precancerous lesion that was treated with cryotherapy many years before. Careful questioning for a history of skin cancer is really critical for these patients, who often don't think to mention this when they're worried about their acute facial paralysis, so it's upon us to ask them. Skin cancers, particularly squamous cell carcinoma, can develop perineural spread along the trigeminal and facial nerves, causing paralysis often many years later. That was the case for the woman in the article, who presented with advanced disease involving both of these cranial nerves. Often the initial imaging in these cases is read as negative, or shows just slight neural enhancement because there's no significant mass visible as the cancer cells just track along the nerve. Repeat imaging can help demonstrate growth or spread of these findings, which would not be expected in Bell's palsy. Another key point from this case is to observe for some amount of recovery for a patient diagnosed with Bell's palsy. A majority of patients will return to normal facial function, while up to 30% will develop incomplete recovery with some amount of synkinesis, but everyone develops some amount of recovery. If there's not clinical recovery of any kind 6 to 12 months after facial paralysis, this is really inconsistent with Bell's palsy, and imaging should be done to look for an alternate cause. In the end, despite Bell's palsy being the most common cause of facial paralysis, we cannot become complacent to think that all facial paralysis is Bell's palsy. Also, we can't always trust that a patient coming to see us with an existing diagnosis of Bell's palsy was correctly diagnosed in the first place. We must remain vigilant to look out for those rare but serious causes of facial paralysis that mimic Bell's palsy, so our patients can get the right treatment right away.